Good afternoon, everyone, and thank you for joining us today for an update on the COVID-19 vaccine with Dr. Jose Gaviria, Dr. Kelsey Williams, and Dr. Amaya. We encourage you to use the chat function to share your questions and comments. We will have a Q&A session with our panelists after their presentations. Following today's program, we will send a short survey. Please take a few minutes to respond and share your ideas so we can continue planning programs that are meaningful and impactful. So without further ado, please help me welcome in our panelists.
Good afternoon. I am Dr. Jose Gaviria. It's a pleasure to be here. Thanks again to the leadership of MCI for putting together this conference. It's a pleasure to share with the other two doctors, Dr. Kelsey Williams and Dr. Amaya.
Kelsey, we can't hear you.
Can you hear me now?
Yes.
Okay, great. Thank you, Dr. Gaviria, for that introduction. I'm Kelsey Williams, and I'm one of the Baptist Hospital Miami infectious disease pharmacists.
Hello, everybody. My name is Lee, and I also work at BHM/MCI with Dr. Gaviria and Dr. Williams. It's a pleasure to be here.
So we are going to touch on different aspects of the COVID-19 vaccine, the variants, the efficacy of the vaccine, adverse effects, and also on use of masks. So we'll start the lecture. Next slide, please. So looking at the disease trends and cases, when we look at the let's have the next slide, please. When we look at the trend of cases here in the United States, we see that by the end of November and December, we had approximately 250,000 cases being reported on a daily basis. Fortunately, the good news is that with the vaccine rollout that began in early to mid-December, there has been a significant reduction on the number of cases reported. And the last few weeks, we have had approximately 35 to 40,000 cases reported nationwide here in the United States. This is very good news for all of us. Next slide, please. So when we look at what is happening worldwide, we see different countries here. We see in burgundy, United States, in blue, Turkey, we have in orange, Brazil, we have India in green. So we see how in the United States, toward November, December, and even early January, we had a significant increase on the number of cases. But as I mentioned earlier, fortunately, greatly due to the vaccine rollout, we have had a significant improvement and reduction on the number of cases. This is the trend in most countries. Unfortunately, we saw this huge spike in India. Now the number of cases in India is coming down with the implementation of measures at the epidemiologic level and contact tracing and prevention of transmission. It seems that the cases finally are going down in India. When we look in Florida, we used to have in Florida approximately 5,000 to 6,000 cases on a daily basis. Now the number is much lower. The cases now are approximately 1,500 cases a day. And another good news is the mortality. At some point, we used to have 50, 60 deaths in the state on a daily basis. Now we have maybe 5 deaths related to COVID-19 in the state. So this is also good news. And as we can see, the metropolitan areas are the ones that have been affected the most. All the tri-county state area, also the counties around Tampa, Orlando, and Jacksonville. So as expected, the metropolitan areas have been the ones affected the most. Next one, please. When we look at the United States, once again, this is the number of deaths that we had. Once again, correlating with the number of cases. Also, there was a correlation and the number of deaths was quite high. toward November and December with around 3,000 deaths on daily basis. Now also the deaths have reduced to approximately 500 deaths or less a day due to COVID-19. So all this is good news. Next one, please. When we look at hospitalizations and people in the ICU, once again, at some point, we have around 130,000 people hospitalized due to COVID-19 and approximately 25,000 people in the intensive care units. Now we have only 30,000 people hospitalized and only around 2,500 people in the intensive care unit. So once again, significant reduction in all these parameters. Next slide, please. Looking at the COVID-19 variants. So what is happening with the variants? The SARS-CoV-2 virus is an RNA virus. There are RNA and DNA virus. The RNA virus has higher tendency to mutate because the genetic material that produces the RNA is not as accurate in replicating the RNA. Some minor mistakes happen in the RNA reproduction of the virus, and these minor mistakes cause changes in the proteins of the virus. Some of these changes could make the virus less fit. Other changes make the virus more fit. Certainly, when the virus is less fit, that strain dies out. But when the virus is more fit, that strain has the tendency to gain control, to increase. We saw a few of these variants, and I'm going to touch on that. Next slide. So the first variant that was reported was the B.1.1.7 variant, was found in the United Kingdom. What happened towards September 2020, the epidemiologic and infection control authorities in the United Kingdom noticed that there was a spike, an increase of cases. In the number of cases, despite the measures that they have, they started looking and they found that the virus had mutated. This mutation conferred to the virus approximately 30 to 70% increase in transmissibility. The protein of the virus, especially the spike protein, those projections that we see when we see the images of the virus, are the projections that allow the virus to attach to the human cells. This protein, the spike protein, has developed more affinity to the receptors in the human cells, so the virus is able to attach to the human cells more efficiently. And that way, the chances of infection and disease are higher. So we noticed that with the UK variant. Then later on, a South African variant was found. There is a mutation that we call B.1.351. The increased transmissibility has not been shown, but what we know about this, at the time that this variant was found, the AstraZeneca vaccine trials were being done in South Africa, and there was a sudden drop on the efficacy of the vaccine from approximately 80% down to 50%. So that also led to the discovery of this variant. Finally, we have the P1 variant that was found in Brazil. Also make the virus slightly more fit. Next slide, please. This is a diagram about the original virus, the native virus, and the variants. So what we see in light orange, in peach color, is the proportion of the original virus. In blue, this is the UK variant. In pink, we have the Brazilian variant, and then in orange, the South African variant. We see, for instance, how in the southeast, there is still a significant proportion of the native virus with equal representation of the different variants. We see that in the northeast, in the New England area, the variants have gained significant proportion, have increased, and now variants are approximately half of the cases in the New England area, with probably a quarter due to the UK variant, then a little bit less the Brazilian, and less the South African variant. We see that in the area of Texas and Oklahoma, still there is a significant proportion of the original virus. And when we move toward the Northwest, the Seattle, Portland area, and LA area, we see that it's a significant proportion of the South African variant. There is a significant African communities in these states, and we see how the South African variant seems to be very significant, has gained significant control, and the numbers are going up. Since these variants are probably more fit than the original virus, what we expect is that progressively the amount of original virus decreases and the variants take control. Next one, please. This is a distribution worldwide. Once again, the UK variant, as expected, has spread all in Europe, in Russia, and most of the Americas, and in general in the Mediterranean basin. Next one, please. The South African variant, as expected, is predominant worldwide in the South African area, in North America, and parts of Europe. Next one, please. And then the Brazilian variant, as expected, has spread all throughout the Americas, in Europe, and somewhat in China and India. Next one, please. This is a busy slide. Basically, these numbers show how, once again, as I mentioned before, as time progresses, the proportion of the different variants has increased. Next slide, please. Finally, and we'll touch more about this in the question and answer session, but basically one important question is, what is the relationship between the vaccines, how effective the vaccines are, and the in relationship to the variants? So what we know is that the Pfizer and the Moderna vaccines seem to retain their efficacy, especially against the UK variant, and still are, although they are a little bit less effective against the South African and Brazilian variants, they still retain significant efficacy, especially preventing severe disease. Another vaccine, the AstraZeneca vaccine, that is not approved in the United States, but is used in Europe and in other countries in Asia and in South America, shows significant reduction on the efficacy in the variants, especially the South African variant. Initially, for the original virus, the efficacy of the AstraZeneca vaccine was approximately 75 to 80%. With the South African variant, the efficacy of the vaccine went down to around 50%. So that's my comments at this time regarding the vaccines and the variants, and I'll be glad to touch back on this in the answer and question session. Back to you, Kelsey. The microphone is mute.
Thank you, Dr. Gaviria, for the introduction. Thank you all for joining. So I'm just going to go over some of the vaccine overview updates. So as Dr. Gaviria mentioned, over the past few months, we've been receiving lots of questions about the COVID-19 vaccine. So in preparation for this presentation, I just compiled some of those questions that we've been receiving, what we've been talking about in the news. So hopefully we can answer those questions, clear up any misconceptions. So if you're here today, you may be debating if vaccination is right for you, and I've come to get your questions answered if you have any potential safety concerns. So before I begin, I just want to say that getting the vaccine is a personal decision, and everyone should do their own homework to decide whether it's right for you. I can say that there's been over 285 million doses of the COVID-19 vaccine that have been given in the United States thus far, and there's only been a handful of adverse effects that have been reported. So which one would you pick? Is there one that's better than the other? So there are an array of different vaccines. On the screen here, you can see that there are 4 main classes. But the ones that we have available to use are the mRNA vaccines, which are the Moderna and PFIZER, and then the viral vector, which is the J&J. So both the Moderna and PFIZER vaccines work the same way. They have similar safety and effectiveness. They both require 2 shots. Therefore, I would recommend just getting whichever one you're able to get. The only caveat to this is for our younger patients that fall in the age group of 12 and up. Since Moderna did not include any patients younger than 18, PFIZER vaccine would be the only one available for our patients that are 18 and are 17 or younger. So what about J&J? The benefits of J&J is that it's not a new technology. Viral vector vaccines have been used for decades. So if you have any like serious concerns about long-term side effects with the composition of the vaccine, this may be an attractive option. We do have long-term safety data on other vaccines of its kind. Additionally, if you are worried about some of the side effects that you've been hearing, like fever, body aches, arm pain, the J&J vaccine did have the least amount of those side effects reported in the trials. And then most importantly, if you're anything like me and you need to put an iPhone reminder for everything, this is only a one-dose vaccine, so one and done. So if this better suits your lifestyle, maybe J&J is the better vaccine for you. So as Dr. Gaviria already discussed, SARS-CoV-2 variants pose a tremendous challenge in controlling this epidemic. The South African variant, the B1 through C1, and the P1 or the Brazil variant have raised questions regarding the effectiveness of vaccines that are currently being used. And there's data that suggests that these may not be as effective for the variant. So the predominant variants of concern are the B117 from the United Kingdom. So although this variant is the most prevalent within the country, we do know that the vaccines are showing good susceptibility. They are showing to be effective, so that is good news. In the study above that we have here, they reported reduced susceptibility to the South African variant for all the available vaccines, but protection was just reduced, so it wasn't completely gone. Therefore, we would still recommend getting vaccinated because likely if you did contract the virus, your symptoms may be less severe. Recently, the FDA did state that they are doing an accelerated review of updated vaccines against virus variants. So more to come on that soon. I know that Johnson & Johnson is developing additional vaccine to be used as like a booster, a booster, and then same with Moderna. They've also developed a booster. So hopefully those show more promise for the variant. So what about the effectiveness? COVID-19 vaccines are safe and effective. COVID-19 vaccines have been evaluated in thousands of participants in clinical trials. Vaccines met the Food and Drug Administration safety standards, met their effectiveness standards. Up here we have a CDC report looking at real-world settings with high-risk populations. And Pfizer and Moderna vaccines were shown to be 94% effective against hospitalization, and then 64% effective in those partially vaccinated and those aged greater than 65. So those had only got one dose of vaccine. And then to receive the most protection, given that difference with the 94 versus the 64, everyone should receive all recommended doses of whichever vaccine they choose. And some people who are fully vaccinated against COVID-19 will still get sick. No vaccine is 100% effective. So experts continue to monitor and evaluate how often this is occurring, how severe their illness is. But all in all, pretty good effectiveness rates of 94%. Is the vaccine effective for transmission? So we no longer have to wear masks if you're vaccinated. So where did this recommendation from the CDC come from? So vaccines offer protection through reducing the risk of severe COVID. They are up to 94%, like we just discussed. And most vaccine effectiveness data that are related to the mRNA vaccines are showing that they are effective even with one dose. In addition to providing protection against COVID-19, there is evidence that shows that it does provide protection against infections, even in those patients that do not have symptoms, so asymptomatic infections. And COVID-19 vaccination can reduce the spread of disease overall, helping protect people around you. So not that I am recommending getting just one dose. you should definitely get both doses of the vaccine. But it is promising to see that in this study, there was patients that only did get that one dose, and they were 40 to 50% less likely to transmit the virus to members of their household. All right, so now we're going to move to talking about safety in pregnancy and adolescence. This is a newish hot topic within the COVID-19 vaccine. So I just want to say that although this is what we were talking about, we have already discussed like the safety concerns in the non-pregnant population. So we are going to just highlight this, but we do know that the safety is promising for those that are non-pregnant. So this study was published in New England Journal of Medicine. They included 3,500 participants in the Be Safe program, which is a voluntary program that the CDC asks any patient that is pregnant that received the vaccine to enroll in. It's a self-reporting system where the women that got the vaccine, they just report if they've had any adverse drug reactions. And all in all, so out of these 35,000 people that were included in the trial, all of which were pregnant, the main side effects that were reported were injection site pain, so very similar to our non-pregnant population, myalgia, chills, and fever was a little less prevalent than the general population. So as far as the nitty-gritty, so did it lead to any pregnancy loss, or was there any reduction in, or any miscarriages? So in here, in the study, they found that 14% of their population resulted in pregnancy loss, and 86% resulted in live birth. So at first, when I read this, it seemed high, but then after doing my own research, I learned that the overall rate of miscarriages in the U.S. is 15% at baseline. Therefore, these numbers should not be considered a correlation to the vaccine necessarily. It's really just the same as your population before outside of the vaccination group. So overall, there really was no red flags with pregnancy, and this is ultimately the trial that led to it being accepted for use in this population. So for those debating whether vaccination during pregnancy is right for them, of course, it was going to weigh the risk versus benefits. So whether pregnancy increases susceptibility to COVID-19 is something that is unknown. Many hospitals have instituted universal screening for all pregnant patients, but they found that the rates of infection are pretty much the same as with those that are non-pregnant. But with that being said, the CDC did a large study to assess whether pregnant women are at increased risk of severe complications from COVID. And they did find that with patients that are pregnant that are being admitted for symptomatic COVID, they were more likely to be admitted to an ICU, more likely to be put on a ventilator, and more likely to lead to death than non-pregnant women of the same age. So this is pretty alarming. Definitely something that should be considered. Above, I have a study to just coincide with the CDC study, and this was done in Sweden. They showed that infants born by mothers that were infected with SARS-CoV-2 infection had a higher risk of neonatal respiratory disorder and other comorbidities. So there was no difference in mortality. So with this information combined with the information from the last slide, the risk of vaccination causing a negative outcome in pregnancy is most likely less than COVID disease would cause in pregnant individuals and their infants. So what about children? So we all know that now children are those 12 and older are eligible to get vaccinated. So although fewer children have been infected with COVID compared to adults, children can be infected with the virus, they can get sick from COVID, they can transmit the virus. On this slide above, this is provided by the CDC. In blue, you can see that this depicts all the patients that were between 0 and 17 years old. As more adults are getting vaccinated, adolescents 12 to 17 years of age are making up a greater proportion of the total cases. So 12 to 17%, 12 to 17 years of age, 9% of that population, 9% of those that were infected with COVID overall in April, 9% of them were in that age group. And then collectively for those 17 and under, that was nearly 20% of the population of those infected with COVID in April. So the approval of the Pfizer vaccine in adolescents is a big win against the pandemic because people aged 21 years old or less, they actually make up 26% of the population. Therefore, with kids going back to school, college, and social distancing being lifted, we need to do what we can to protect our kids so they aren't spreading it to others and especially transmitting it in the household. Overall, the rates of serious illness in children are low, and adolescents usually are asymptomatic, which is great, but it's also not great because we won't know that they have symptoms, we won't know they have COVID, they come home, they transmit it, and then they put our older population at higher risk. So getting a COVID-19 vaccination can help protect your child from getting COVID. And early information shows that vaccines may keep people from spreading COVID-19 to others. So how effective has the vaccine been in preventing COVID in this pediatric population? Well, it really didn't get much better than this. It was 100% effective at preventing COVID-19 with symptoms in children 12 through 15 years old, and those that got both doses of the vaccine. In addition, children's immune system responded to the vaccine the same way that adults did. And to get the most protection, your child will need to get 2 shots separated by 21 days. Of course, we want to know, are they safe? Yes, they're safe. Really no big things to report. The clinical trials for the children, there was no safety concerns. There was no cases of anaphylaxis, no cases of Bell's palsy. Both of these were seen in low incidence in adults, but just interesting to note that that wasn't reported at all in children. The only side effect reported was lymphadenopathy or swollen lymph nodes on the arm, on the side that they received the vaccine. But this was a result on its own. There was no big deal, and no treatment was needed, and it resulted in around 2 to 10 days. So this wraps up the portion about children and vaccination of pregnant patients. So we will move on to COVID-19 vaccine and blood clots, as this is something that the news really loves to talk about. So I just want to reemphasize that this topic was chosen not because it's prevalent or something you should be concerned about, but more because it's a hot topic in the news. We just want to give you our point of view on it and answer any questions you might have. So vaccine-induced thrombosis and blood clots. To date, the CDC system has been monitoring safety of these vaccines. They've only found 2 serious types of health problems after vaccination. They're both rare, but they were anaphylaxis and then thrombosis with thrombocytopenia syndrome, or TCS, better known as just blood clotting. So this was seen with the J&J vaccine and AstraZeneca. This is a very rare risk, but it's seen in patients with low platelets. And then women younger than 50 years old should especially be aware of their increased risk for this rare adverse event. All of the patients that did report having this occur were of childbearing age. So again, this adverse event is rare. It occurs at a rate of about 7 per 1 million vaccinated women, so extremely low, and much lower than if you were on birth control. And the J&J, because of this, J&J temporarily paused its production in the U.S. due to an abundance of caution and to raise awareness. But after the group met and voted on whether or not this was something that needed to be concerned, they weighed the risks and benefits. They found that the incident was overall low, and the FDA and the CDC lifted that pause on J&J vaccination and determined that the benefits did outweigh the risk. So to finish off, I just wanted to share the recent changes and updates on the CDC vaccine guidance, all of which can be found on the CDC website. Main things: COVID-19 vaccination is recommended for all people aged 12 years of age or older, even for those that have been previously infected. As we previously discussed, these vaccines are safe, they're effective, they're okay to use in children, okay to use in pregnant individuals, and they're recommended for those that have been previously infected. Once you're fully vaccinated, you can resume activities that you did prior to the pandemic, live your life mask-free. And now I'm going to introduce my colleague, Dr. Amaya, and he will discuss vaccine boosters and vaccination in immunocompromised adults.
Thank you, Dr. Williams, for that wonderful introduction. Hi, everybody. So today I'm going to be talking about kind of a follow-up from our last webinar in February, specifically immunocompromised patient population and hosts. So last time we talked about specifically oncology patients and cancer patients. So I just wanted to give a little bit of a refresher / summary of last time, kind of the meat of last time's topic. Basically, the immunocompromised patient population, especially patients with cancer, are at an increased risk of complications with COVID-19 or the SARS-CoV-2. So the benefits still currently, even from last time, seem to significantly outweigh the risks if you become vaccinated versus being unvaccinated for these patients. And the National Comprehensive Cancer Network, or NCCN, they did have an update from previous presentation, but a very minor update, but they still recommend that all cancer patients receiving active therapy get vaccinated. They also do recommend that caregivers and family members and friends who are closely associated with the cancer patients also get vaccinated to protect that cancer patient because they are at a higher risk for complications. These vaccination, let's go back. The vaccination for these patients needs to be discussed with an oncology physician or a pharmacist still, because we'll go over the data in the next few slides, but there are different cancer types: blood cancers, solid tumor cancers, and even within those, there's different types of cancers. The therapy that you're going to be on because of that will dramatically affect your immune response, which we also go over here in a little bit. So this is the summary of a previous presentation, a little bit of update for specifically for our patients with cancer. So now we can move on to the next slide. Before I get into that, I still wanted to go over the immune system defenses to illustrate why some cancers and some of our immunotherapy or some of our medications or chemotherapy can really affect the immune system and what kind of effect it has on the vaccines themselves. So on the right-hand side, there's two main defenses for the immune system in our bodies. We have the adaptive immune system and the innate immune system. So on the right-hand side of this figure here, I want to talk about the innate immune system. So this one happens very quickly. This is kind of a lot of our cells on the right-hand side will actually protect us from things that happen if, say, you have from the shot itself. So if you get the COVID-19 vaccine or any other vaccine, you'll probably experience some arm pain. And that's because you have a lot of your host antibodies or T cells going at that particular site very quickly. And also you have your mucosa in your mouth and your GI tract that also protects against some of your foreign substances that are introduced into the body. So this is kind of your first line of defense. Then if we move on to the left side, we have the adaptive immune system. So this takes a little bit longer. The other one is pretty immediate, where this one takes days to weeks to actually work. And this, you actually form antibodies over a long period of time. So this is kind of the effect that we have on vaccines and natural immunity. Initially, you'll have presenting a foreign antigen to the cell itself, to like a B lymphocyte or a B cell, and then later on it'll create antibodies. And it doesn't do that without the help of some T cells as well. So there's two different types of T cells. There's CD4 and CD8, but just know that one is a T helper cell, and then that actually helps the B cells produce those antibodies, as well as it does have some effect on viruses. So we really need both the B cells and the T cells within the adaptive immune system to create those antibodies later on. That way we can have an effect. We can protect the body from that foreign substance such as a virus. So we can go to the next slide. I think you have to tap a couple times. So I just wanted to illustrate that part right there. So now the goals of antiviral therapy, there's two main goals here. One is to prevent infection, and the other one is to reduce severity of infection. So the prevention of infection is actually related to the B cells and the antibody development and the T cells helping them. Where the reduced severity of infection, reduction severity of infection is via the T cells mostly. So we look on the right-hand side here at the top right, we have that B cell production of antibodies, and that helps us protect against the infection later on, because that does take the immune system a lot longer to actually create an immune response. Now at the bottom hand of the screen is kind of that T helper cell helping the B cells initiate those antibodies. And then we also have some CD for the T helper cells, helping the plasma cells within the germinal cells create more antibodies there. And that can happen later on, as well as there's other T cells, not only related to helping the B cells, but we have those T cells, different cytotoxic T cells within the innate immune system that also can help fairly quickly. So I just wanted to highlight those 2 points here on this slide. So now we can go to the next slide. Now I would like to go over some of the studies that have come out recently since the last time we spoke about medications and their effect on the immune response to the COVID-19 vaccines. So this is actually a preprint that has not been peer-reviewed yet, but it was published in April. And these were looking, the evaluators were looking at patients who received the COVID-19 vaccine who had a chronic inflammatory disease, so an autoimmune disease of some sort, versus healthy adults. And what they did was they measured antibody levels after 2 doses of the COVID-19 vaccine, specifically their mRNA vaccines. And what they wanted to see was whether or not those patients, after the 2 weeks of having receiving those 2 doses of the mRNA vaccines, because per the studies, it takes at least 2 weeks after your last dose to get that full effect, to see what the antibody level titers were in those patients. And there was a myriad of different patients in this study who were receiving different medications. So they looked at the different medications to analyze whether or not they reduced antibody levels. And what they found was there was at least a 3-fold reduction across the board, but B cell depleting medications such as rituximab, which is a medication used a lot in our cancer patients, specifically our hematologic malignancy patients, so lymphoma, had a 36-fold reduction in antibody titers, which is very, very dramatic. Additionally, steroids had a big impact on the reduction, 10-fold reduction there. So that's your prednisone. And they didn't find that the dose of the prednisone, so say like a low dose versus a high dose, made any difference. They still found that 10-fold reduction regardless of what the dose was. And then there are several other immunosuppressive medications that these patients were on, anywhere from 2.5 to 4.5-fold reduction. So this study really highlights that although patients who are immunosuppressed receiving the vaccine can still not mount that antibody response that we were talking about in previous slides well enough to be protected. So now we can go to the next slide. Now there are multiple other studies looking at antibodies after this 2 doses, specifically in disease states and not necessarily the medications themselves. There are 4 disease states I wanted to highlight. So all of these are fairly recent, and there's several studies here. First of all, it would be the hematologic malignancy population, so a lot of our lymphoma and leukemia patients. Second would be our solid tumor patients. So those are our breast cancers or our gastric GI cancers. Solid organ transplants, so that's our liver and kidney transplants, and also autoimmune diseases, so rheumatoid arthritis and other disease states along those lines. So in the hematologic malignancy cancer patient population, there is, probably 3 or 4 or 5 studies. There's new ones that come out almost on a daily basis here, but they did try to look at what the antibody effect was on with those patients. And they found anywhere from 39 to 54%, depending on which study you were looking at. However, it really depended on where they were at in their therapy, what medications they were getting, and how severe the hematologic malignancy was. So even though that's kind of the average from 39 to 54, there were some patients actually in CLL who had a much less antibodies after receiving their doses of the vaccine. Additionally, they also found that if you only received 1 dose of the PFIZER vaccine, there was a lower production of antibody levels. So what these studies kind of indicate to us is that you really do need to follow up to get the second shot if you receive the mRNA vaccine, such as the Moderna or the Pfizer vaccine. Now, if we move on to the solid tumor patients, now the solid tumor patients, there was 55 to 95% after the second dose. But this really depended on the cancer type and what chemotherapy regimen those patients were on. But for the most part, these patients tend to have a higher level of antibodies compared to the hematologic malignancy cancer group. And that's simply because they don't receive as intensive chemotherapy as the hematologic malignancy group. Now, for solid organ transplant patients, this was kind of on the same lines as the hematologic malignancy patients. And this is because a lot of our solid organ transplant patients are going to be on immunosuppressive therapy for life. So this includes some of your steroids and mycophenolate and cyclosporins. So these are all medications that help reduce the immune system so the body doesn't attack the organ that was transplanted. Now, they did find in these studies that mycophenolate was associated with a significant reduction in antibody levels. So again, for these patients, it's important to take that into consideration. Lastly, the autoimmune diseases, and just like the previous slide, this is just summarizing what that said. So there's at least a 3-fold reduction in patients who are receiving any types of medications for those, and 36-fold reduction for the B cell depleting agents. So this is all important to take into consideration, because even though the vaccine is recommended for all of these patients, they do have a lower antibody response to the vaccine itself. So now we can move on to the next slide. And just to summarize what we talked about in these previous slides is that B cells, they form those antibodies, but they do work closely with T cells to do that. And both are actually needed to produce an immune response. So there's also a previous study that looked at seeing what the correlation between a T cell and the B cell was, what those titers are, because in a lot of studies, they don't measure T cells. However, in the phase 1 and some of the phase 2 trials of these COVID-19 vaccines, they did measure T cells. And what they found was not in immunosuppressed patients, but in just the general patient population, they did find that those were elevated, and specifically the T helper cells that work alongside the B cells. So it's very, very important to take those into consideration, that they're both needed to form the immune response. Next is the vaccine efficacy and immunogenicity data in these patient populations is still lacking. Although we have several studies, the studies are fairly small, and we still need to have more actual clinical data to say if, we're measuring antibody response. We're not necessarily have a lot of data stating what the reduction in hospitalization is or the transmission in these patients. So although we have that specific data showing the decrease in antibody production, the degree is also reduced depending on what cancer type, what immunocompromised condition there is, and the different timing of the medications associated with that. And lastly, I wanted to point out on this slide is that second dose of the vaccine, specifically the mRNA vaccines, is very important, especially for older and immunocompromised patients, in order to us to get enough of that antigen to form that immune response. So now we can move on to the next slide. So the next two sections I want to talk about is the booster. This first one is the booster data against variants. So Moderna did post something earlier this month stating that there might be a need for a booster vaccine against the variants of concern for the COVID-19 or SARS-CoV-2. And that's because, we've seen these variants come from different countries in the global to the United States, and there have become more prevalence. And we do know that some of our medications don't work as well against these SARS-CoV-2 variants. And there has been some data saying that there might be some resistance specifically to our vaccines. However, this is a preprint of some data, a press release of some data, but the actual data has not been fully released yet. So I do think there are some ID experts and virologists who are still waiting to see this data, who say that maybe we need one, maybe we won't, but I think that's yet to be determined. I will say that there have been studies looking at other vaccines, not necessarily the COVID-19 vaccines in immunocompromised patient populations, specifically cancer patient populations, who have done more than just the 1 or 2 doses specifically for either the flu shots or the Zostavax shots, so that's the shingle shots. And they had to have a little bit more than just the 1 or 2 recommended doses to actually form that antibody response. So potentially for the immunocompromised patient population, this might be needed. Potentially it might be needed for the variants of concern, but I think that's yet to be determined. So we can go to the next slide. And lastly, to end today's presentation, I wanted to talk about the CDC recommendation about masks. So as Dr. Williams touched upon earlier in her presentation, the CDC does state now that if you've been fully vaccinated, you can resume activities prior to the pandemic normally without wearing a mask. And they define you being vaccinated as if it's the 2 weeks after you received your last dose of that vaccine, whether that be the 2 mRNA vaccines or the J&J vaccine with the 1 dose, just 2 weeks afterwards, because it does take that amount of time to form the immune response. However, talking about the immunocompromised patient population, those patients are still going to be at risk. So I do think it's important to take that into consideration and thinking about, do you know anybody in your family who is immunocompromised? It still might be a good idea to wear that mask and do social distancing if there's not a lot of people surrounding them that have been fully vaccinated, because they are still at risk to contract disease, as shown by the previous studies that I went over. So I do want to make that point here. So now we can move on to the next slide. The reason why the CDC went to make that recommendation of you don't have to wear a mask is because of all of the data here presented on this slide. So this is a slide from the University of California, San Francisco Division of HIV. Dr. Monica Gandhi put this together. So she summarized all of the studies looking at asymptomatic transmission. So this is after the vaccines, after receiving their vaccines, the viral load in the nares. So patients were tested to see if they were carrying any of that in their nasal pharynx right there. And what they found was most of these patients, after they received the vaccines, specifically that largest study here in the middle from the Israel Ministry of Health, 94% of patients did not have, 94% of patients had a reduction in asymptomatic infection or transmission. So this is where the CDC, all of the evidence that they had to make that recommendation to not have a mask anymore. So now we can end today's presentation. I think that's my last slide for today. And we are happy to take any questions that you may have for us.
Thank you so much, Dr. Amaya, Dr. Gaviria, and Dr. Williams. This was an exceptional presentation and a great update for all of our audience. So now I'd like to encourage the audience to submit any questions in the chat. We have actually received quite a few that I'll start reading now. So the first question we have is, do you think the age limit for the vaccine will be going down to cover younger children?
I could take that one. So I think that both Pfizer and Moderna have already looked into the efficacy of these vaccines for ages 6 months to 11 years old. Their main question is really not whether it's effective, it's whether the dose needs to be changed. So experts believe that it's going to be efficacious and it's not going to cause safety concerns, but it's likely that a 6-month-old is going to need a much smaller dose than an adult. So that's really what they're investigating now, and they're expected to release the results in the fall.
Thank you, Dr. Williams. The next question is regarding just the spikes as we saw in the graphs that you presented. There has been quite a few spikes since last year. Do you predict another spike later this year?
I can take that. So I am optimistic. I think that is unlikely. I think that especially with the vaccine rollout and as hopefully more and more people becomes vaccinated, we could get close to the point that we have herd immunity. We are still far away from that, I believe, at this point, between the people who have the disease in the United States and the people vaccinated. The percentage, if I remember correctly, is around 40% or so, 40–45%. We need around 75% or so of immunity to reach herd immunity. I hope that more people gets vaccinated and hopefully we won't see any spike. I doubt that will happen, but of course it depends a lot on the behavior of people, transmissibility, and how many more people get vaccinated. Any other opinions from Dr. Williams or Dr. Amaya?
I don't know, I'm feeling a little less optimistic just because now they're saying that to reach herd immunity, we have to get to probably 85–90% of the population vaccinated, just given all the variants. So if like currently in Dade County, for instance, 40% of the population has received 1 dose. So, I mean, we're not even halfway there. So now that we've listed restrictions, and there's really no way of knowing, when you're at the grocery store, there's really no way of knowing who's vaccinated and who's not. So, you know, it's really all on the honor system. So hopefully there's not another spike, but if people are not continuing to get vaccinated and we're stagnant at the 40%, then I would expect a spike, but fingers crossed.
I think actually that leads us to our next question. I know Dr. Amaya mentioned a little bit about the change in the CDC guidelines, but we've received this question quite a few times already that says, as a person who has been vaccinated, is it really safe to go back to normal and stop wearing the mask as the CDC suggests? So I just wanted to have like a summary for the few people that asked the question again, if we can get just, you know, give them a little bit of peace of mind.
Sure. Yes, I can go ahead and take that question. So, you know, the reason why we have vaccines is to go along, you know, about our normal life as we used to. So there are several other diseases and viruses that we take vaccines for in childhood, so we don't have to wear a mask and we feel comfortable going out. Obviously, nothing is 100%, as Dr. Williams had presented earlier, but it does a pretty good job. The 90, the 95% of, you know, leaving us rest assured, because I do think that we can't go along living a life being scared of becoming, you know, infected with a disease or a virus or a bacteria. You know, that's why we have vaccines, and that's why, you know, we're all here giving this presentation today to kind of rest assure everybody that, you know, vaccines are good. We have lots of previous experience with other disease states that prevents the infection and the transmission of them. So although I can't give you a 100% answer, like you're going to be 100% safe, the vaccines do a pretty good job of making you really, really safe, just not 100%. And that going back to normal life, although it does feel kind of awkward and weird, because I do, you know, after several months or a year of having to wear a mask, and now all of a sudden you become vaccinated and you don't have to anymore. I do think that is a little bit weird. However, you know, it was kind of weird to even put the mask on in the very beginning. So it's just going to take time for us to get back to that point. But I do think it's a step in the right direction.
I want to make a couple of comments. Number one, something that is very important to keep in mind is that the efficacy of a vaccine is measured by the vaccine preventing you from going into the hospital, having a severe illness, or from dying from the disease. So that's very important to keep in mind, because sometimes people say, well, I got the flu vaccine or the COVID vaccine and I still got the illness. If you get the illness, but the illness is mild and you don't need to go to the hospital, or God forbid you don't die, then it is considered that the vaccine is a success. So it is also something very important to keep in mind. The other aspect is the adverse effects. Nothing is, as we mentioned before, 100% safe. There are some adverse effects, but we need to keep in mind that having the illness also have lots of adverse effects. People can have thrombosis when they have COVID-19. People can have Bell's palsy. People can have different conditions and really, really bad conditions as complications of COVID-19. So sometimes a few cases are reported with the vaccine, but when we put into context, the vaccine is much safer compared to having the illness. So I just wanted to comment that.
Thank you very much. And now that you're mentioning adverse effects, we have quite a few questions about that. So can the vaccine affect fertility?
I can take that one. So it doesn't affect fertility. There is confusion about that after a false report surfaced on social media. The doctor that did make that false report, she's like a homeopathic doctor. She's a gynecologist. She doesn't specialize in virology, infectious disease. She really has no education whatsoever in IV or virology. So she made a claim that was completely inaccurate, and she said that the spike protein had something to do with the attachment of the placenta. But it doesn't. So the vaccine is really just a set of instructions that teaches your immune system how to make spike proteins to protect yourself from the virus. But there's nothing that has proven to affect fertility. Even in the trials of patients that got involved with the initial trials to get the vaccines on the market, there was multiple women in those trials that got pregnant, and they have had no issues.
Thank you, Dr. Williams. How about if the person is breastfeeding? Is it safe to get the vaccine if you're still breastfeeding? Can that be passed on to the child?
I can take this one. So yes, it is safe to breastfeed. Honestly, on the CDC's website, they talk about how it might actually be beneficial because then your baby could get those antibodies through breast milk. But there is no contraindication to breastfeeding when you get vaccinated.
Thank you. The next concern is about blood clots. It says, I got the Johnson & Johnson vaccine. How would I know if I get a blood clot?
I can take that. Well, the blood clots that have been reported, is important to mention, have been relatively few. For instance, with the first, have been just anecdotal reports. Most of the blood clots have been either in the abdomen, and they usually present with as abdominal pain, nausea, and vomiting, or in the brain, that they may present with, excuse me, they may present with as headache, altered mental status, confusion. So that's usually the way that they present. When they went and looked back into the cases, especially with the Pfizer, Moderna vaccine, or Johnson & Johnson, they found that there was no increase in the number of cases compared to the baseline population. We have to keep in mind blood clots happens to people in the general population every day in a small amount, of course. So always when this happens after a medication or a vaccine, we have to put that in context with what happens in the general population. And there was no an increased number of cases. With the AstraZeneca vaccine, there was an increased number of cases, and it was especially found in younger women. The reason is not very clear. It may have something to do with a receptor in the platelets. So at this moment, the AstraZeneca vaccine that is not being given in the United States anyways, is not recommended in women younger than 50 years of age. But for the vaccines that are used in the United States, there is no contraindication.
Just to piggyback off of Dr. Gaviria, just in general, so vaccine side effects usually occur, if they're going to happen, they usually occur within like 6 weeks of getting the vaccine. And so with this information, when they did all these trials to ensure safety and efficacy, the FDA required each of the authorized COVID-19 vaccines to be studied for at least 2 months, so 8 weeks, rather than the historic 6 weeks after the final dose, and they didn't find any issues. So just to answer your question about how long would I know, I feel like it would be safe to say 6 weeks is generally when side effects occur after vaccine.
Thank you both. Now going back to the booster, are the boosters going to have only the variant booster, or does it include the initial full vaccine dose and the variant dose?
I can take this question. So I think that's yet to be determined. From the press release, it looks like there might be, trying to cover an additional strain, but we don't necessarily know that at this time yet.
Thank you, Dr. Amaya. We're still getting quite a few questions, so we're trying to get to all of them. What is the longest period that you can have between the first shot and the second shot of the Pfizer vaccine?
So it's recommended to get the vaccine for Pfizer 21 days and then Moderna 28 days. But with that being said, they have extended, and Leo, Dr. Gaviria, please correct me if I'm wrong, but I believe that they extended it to just recommend that you get it within, if you missed your 28-day window, they've expanded it to 6 weeks, I believe.
Correct, yes. Mm-hmm.
So 21 days would be ideal, but if you have a circumstance where you can't get vaccinated, then ASAP, but 6 weeks is the window.
Yep.
And even past the even if somebody is past that 6-week mark, they can still probably get the vaccine. It's just recommended to get it within that because that's the way it's been studied, and we have data within that window. Past that window, we don't have a lot of data, and that's why they're make that recommendation. But I don't foresee it being an issue getting a second dose past that 6 weeks. Just within that is recommended.
And what is the protocol if the person gets diagnosed with COVID in between their first shot and second shot?
I can take that one. Well, usually what we do, we treat the person depending on the severity of the illness, the person gets treated. And then the recommendation is that approximately 2 weeks after the person recovers from the COVID-19 vaccine, the person gets the second dose. Certainly, the person needs to meet the requirements for isolation. For somebody who had mild or moderate illness, is 10 days from the onset of illness, considered not contagious any longer, or somebody who had a severe or critical illness, 20 days. So basically, approximately 2 weeks or so after the person recovers.
Thank you, Dr. Gaviria. Is there a risk to combining vaccines? So for example, the first dose AstraZeneca and then the second dose of Pfizer vaccine?
I'm sorry, just to repeat, did you ask if it was okay to mix and match the vaccines?
Yeah, if there's a risk to mix and match the vaccines.
So there hasn't been anything that I have read about any risk, but just from the way that it was studied, it hasn't been studied that way. So they recommend that you stick with the same vaccine. With that being said, the CDC did say that if, say you get dose 1 with Moderna or dose 1 with Pfizer, and then you realize that you don't have access to a second dose, they did say that it would be fine to get the second shot with Johnson & Johnson. So since they made that recommendation, I feel like you can extrapolate that to say that it would probably be fine, but that's really only if you don't have access.
Thank you, Dr. Williams. Is there a test that can measure how many antibodies you have, and do we know at what level you are protected?
I can take that one. There is a test, and the specific name of the test is the semi-quantitated spike protein antibody. This is a test that is specific to look at the response to the vaccine. It's not the test that we do to look for the illness. Now, having said that, there is actually no indication to test either people who are immune competent or people who are immunosuppressed. There is no indication at this point, no guideline that one has to do antibodies after the person receives the vaccines. But yes, there is a specific test to look at the response of the vaccine. Usually the limit is less than 1 is considered that there is no protection. Above 1, the number can be as high as 20 or 50. The person is considered to be protected.
Thank you, Dr. Gaviria. There's a question here about immunocompromised patients. Can they remove the mask as well now that the CDC has changed the guidelines?
So I can take that one. For immunocompromised patients, I think it's because even if they receive the vaccine, they're still probably not as protected as someone who is immunocompetent, so a healthy individual who has gotten that same vaccine. So I would caution them to remove to take that mask off. I think it's important still for those patients to keep that mask on. Even in the hospital for some of our bone marrow transplant patients and some of our heme malignancy patients, we still, even when they walk the halls before COVID, to have a mask on to protect them from some of the anything foreign that might enter. So I would consider patients who have received a vaccine, who are immunocompromised, who are receiving any type of cancer therapy or solid organ transplant, to be considered almost being unvaccinated, simply because of the small amount of data that we have now saying that they don't have enough of an immune response to mount. So I don't think it is safe at this time, although that's just based on the data presented today.
I have to agree with Lee here. My grandfather actually is an immunocompromised patient. He's receiving T-cell therapy. And he got vaccinated. He took the recommendations of his oncologist. He wanted to find out if he had antibodies. He did an antibody test, and he didn't have any antibodies. So with that being said, he's not vaccinated. So I would recommend, just given like a personal experience, I would recommend keeping the mask on as well.
Thank you both. The next one is a little bit of a lengthy question, so I'll read it. I belong to a tinnitus support group where I am seeing dozens of new members joining who never had tinnitus after they took the COVID vaccine. The vaccine is also making it much worse for many people who already have tinnitus. Is there any information on this? And would you recommend someone already suffering from this to still take the vaccine when their standard living could be affected?
I can take this question. So there is a study looking at some of the information in the VAERS system, so the vaccine adverse effects system from the CDC, and it looked at 140 or some patients or reports who had sudden hearing loss and deafness or some sort of, hearing associated adverse effects from the beginning of when the vaccines were rolled out to about March. But they only found about 40 of those patients actually having suspected hearing loss due to the vaccine. And they also indicated that it's very low as far as like what the rate is, or the incidence of like 0.3 per like 100,000 per year. So a lot of experts will say there's actually not enough data to make a correlation or not correlation, but causation that the vaccine causes any type of hearing loss or tinnitus. So I think it's too early for us to say that there is, but we also can't say that there isn't. Similar to a lot of the other adverse effects that we've seen so far, such as blood clotting. There was a signal saying that maybe there's a safety concern that it's causing that, but now there might not, we found out there wasn't via that particular vaccine. So as far as we know as right now, I don't think there's enough data to say that there is.
Thank you, Dr. Amaya. The next question says, COVID has been transmitted to pets and zoo animals from humans. What research is being done to see if we can expect zoonotic transmission from them back to us?
I am not aware of any study. I don't know if...
I was going to say the same. I haven't looked into that, and I am not aware of any studies either. I'm sorry.
Thank you. Are there any studies that show the vaccine can cause joint and muscle pain?
So joint and muscle pain is a side effect that has been reported. It's usually just like, within the 7 days following the vaccine. But there hasn't been like an overwhelming amount of data that has pointed to the vaccine causing that long term. It's really just been short term, usually 72 hours after vaccination, and then it resolves.
Yes, I agree. Basically, what we see is that after most people get the vaccine, there is what we call reactogenic effect, and it's basically the immune system reacting to the vaccine. So you could have a little bit of a low-grade fever, headache, maybe body aches, like getting a viral illness. That happens, of course, when we get the flu or the common cold. Some of the symptoms that we have is actually our immune system reacting to the virus. Sometimes the symptoms are not even caused by the virus itself, but it's the immune system reacting to it. So some of these symptoms that we have in the first 24, 48 hours after we get the vaccine are what we call reactogenic symptoms to the vaccine. The immune system is a little bit hyperactive. Sometimes we see those symptoms happening more often after the second shot of the vaccine, because of course the immune system is already primed. But those symptoms usually go away after a few days or a couple of days. I am not aware of any of those symptoms persisting for weeks or months.
Thank you very much. And now that you're mentioning the side effects of the vaccine on the days after you get the shot, can you explain a little bit of the reason why some people might get a lot of side effects, a lot of maybe joint pain, or a little bit of, like you said, flu symptoms, and some of them might not get anything at all?
Well, I mean, it all depends on the I believe the genetic and the immune makeup of each person. We know that younger people have more symptoms compared to, for instance, people older than 65. We know that people older than 65 have less of these reactogenic symptoms. I imagine because of the immune system is already a little bit lower compared to somebody who is younger. And as I mentioned before, sometimes we see these symptoms more often after the second dose in the vaccines that are given that have 2 doses. So once again, it's because the immune system is already heightened, it's a little bit primed, so it reacts in a higher way. Any other comments?
Thank you, Dr. Gaviria. Any other comments from Dr. Amaya or Dr. Williams? Okay, well, we actually were able to go through all the questions we received in the time that we had. So thank you so much to all of you for this exceptional presentation, and thank you to our audience for joining. We did record this webinar, and if you're interested in receiving the recording, please let me know. When, like I mentioned, I'm gonna be sending a survey right after. So if you're interested, please reply to that email and we'll be happy to send you the link once it's ready. Thank you so much for joining us today. I hope you have a great rest of your week. And thank you, Dr. Gaviria, Dr. Williams, and Dr. Amaya for your time.
Pleasure. Thank you very much.
Thank you.
Thank you for having us.